All right, today we're putting on our detective hats. We're going to solve a couple of medical mysteries where the crime scene isn't a dark alley, it's the human mind itself. We've got two cases, two people whose brains seem to have turned on them. So let's start gathering the clues. I want you to imagine this for a second. Someone you love, a family member or a close friend, just isn't themselves anymore. All of a sudden they're confused, maybe paranoid, maybe they're seeing things that you can't. It's a terrifying thought, right? And it immediately makes you ask, what on earth is happening inside their head? So, let's open up our investigation with case file number 1. The big problem here is sudden, really intense confusion. Our first job as detectives is to figure out the source. Is the mind just failing on its own, or is the body sending it some seriously messed up signals? Okay, here are the facts of the case. Our subject, a 78-year-old man. And here's the most important detail right off the bat, the timeline. This confusion came on fast. We're talking just within the last day. For any detective, that is a massive first clue.
Now let's get the witness testimony. His daughter tells us he's agitated, he's disoriented, he's even having visual hallucinations. And this is a classic, he's seeing bugs on the walls. Then we get two more critical pieces of info. He's having trouble urinating, and he just started a new medication, oxybutynin. You know, in an investigation like this, every single detail matters.
Testimony is one thing, but a good detective needs cold, hard evidence. And that's exactly what the lab results give us. So take a look at this. His white blood cell count, the WBC, it's up. His C-reactive protein, or CRP, that's a major sign of inflammation, it's way high. And the urinalysis shows leukocytes and nitrites, which are basically screaming infection. The evidence is definitely mounting that his body is in the middle of a fight. Okay, detective, your turn. You've got the clues. A sudden mental shift, clear signs of an infection, a new medication in the mix. What's your top theory? What's really going on here? All right, let's bring in the lineup of usual suspects for a case like this. Could it be a simple UTI? Maybe a complication from diabetes? A bad reaction to that new drug? Could he just be dehydrated? Or is this the beginning of something much more serious, like sepsis? Let's see which one fits all the evidence. And the diagnosis is delirium, triggered by a urinary tract infection. Now, delirium isn't really a disease on its own. It's more like a state of acute confusion, like the brain's fire alarm going off because there's a fire somewhere else in the body. And what's wild is how a simple infection can have such a huge, sudden impact on the brain, especially in older adults. But hold on, what about the other suspects? Dehydration seemed plausible, right? I mean, his sodium was a little high, he looked dry, but that, my friends, is a classic red herring. Dehydration alone just doesn't explain the fever or that high white blood cell count, and a good detective can never, ever ignore evidence that doesn't fit the theory. That new medication, the oxybutynin, was another really tempting lead. It's known to cause confusion, so it fits. But again, you gotta look at all the evidence. A drug reaction isn't gonna cause a fever or shoot up inflammatory markers like CRP. The medication might be an accomplice, maybe making things a bit worse, but those signs of infection point straight to the real culprit. Case closed. All right, let's move on to our second case file. This time, the mystery isn't about a sudden breakdown. It's more like a slow, creeping siege on the mind itself, and it's leading to some really bizarre behavior. Our subject is a 19-year-old student, and the timeline here? Completely different. This isn't a 24-hour thing. His flatmates have been worried for 2 weeks, and, his grades suggest the problem has been brewing for even longer than that. The testimony from his flatmates paints a really disturbing picture. He's pulling away from everyone, he's been heard talking to people who aren't there, and he's developed these paranoid beliefs that someone is poisoning his food. Oh, and there's this one other detail, daily cannabis use. These clues are worlds away from our first case. And here's where this case gets really fascinating. We run all the tests, blood work, a detailed MRI of his brain, the whole shebang, and everything comes back completely normal. No infection, no metabolic issues, nothing. The only thing that shows up is cannabis in his system. And this is a pivotal moment in the investigation, because in a case like this, the lack of physical evidence is the evidence. So with no physical illness to pin this on, where do we look now? All the clues are behavioral, the withdrawal, the hallucinations, the delusions. What's your diagnosis for this young man? Our lineup of suspects has totally changed. Now we're looking at primary psychiatric conditions, things like schizophrenia, or maybe a psychosis that's just caused by the cannabis, bipolar disorder, you name it. The investigation has moved from the body to the mind itself. The most likely diagnosis here is schizophrenia. This is a primary psychiatric illness, something that fundamentally changes how a person's brain perceives reality. It's characterized by the exact mix of symptoms we're seeing: the hallucinations, the delusions, pulling away from people, and a big decline in functioning. And it almost always starts to show up in young adulthood. But I know what you're thinking. Wait a minute, what about the cannabis? It seems like the obvious answer, right? And that's a great question, but it's also the biggest red herring in this case. See, while cannabis can definitely trigger a psychotic episode, that episode usually fades when the person stops using. In this case, the symptoms are sticking around and even getting worse. The cannabis might have been a trigger, a risk factor, but it's not the underlying cause. So, we have two solved cases. Both started in a pretty similar place, someone's mental state going off the rails. But they ended up with completely different conclusions. And this really shows you the core challenge for any medical detective working on that fuzzy border between the mind and the body. Let's just put them side by side to make it crystal clear. Delirium, it's sudden, it fluctuates, people can be fine one minute and confused the next, and it's caused by a physical illness. Schizophrenia, it's a gradual onset, it's persistent, and it's a primary illness of the brain. And getting this right isn't just an academic exercise, it's everything. One needs antibiotics and can be totally reversed, the other needs long-term psychiatric care. So after all that, what have we learned? What are the big takeaways from our two investigations? This is basically the core of the medical detective's handbook for figuring out what's wrong when a mind starts to falter. It really comes down to three fundamental principles that every medical detective has to live by. First, the timeline is everything. Sudden onset almost always points to something physical, like delirium. Second, body before mind. You always have to rule out physical causes, infection, drugs, metabolic problems, before you even think about landing on a primary psychiatric diagnosis. And third, you have to see the whole picture. A good diagnosis isn't built on just one clue. It has to explain all the evidence, even the parts that don't seem to fit at first. And that leaves us with one final, pretty crucial question to think about. These cases just brilliantly show how deeply connected our physical health and our mental state really are. It makes you wonder, doesn't it? How many other conditions out there show up first, not as a pain in your chest or a fever, but as a subtle, troubling change in the way we think and behave?